Are we ready? Okay, let me know, Tiffany.
We're on.
Okay, we're live. Hello, everybody. Happy afternoon, Tuesday afternoon. This is Victoria Stephen. I'm the interim executive director of the IECHI, and we appreciate you joining us today. You're not going to see me, apparently. My video decided that you should only see my picture, so that's what you get today. Anyway, we are very pleased to have you here today. This is our third health education forum for the 25-26 program year. We're going to do things a little differently today because we have a very full presentation for you. And so we're going to do a couple of things. One, we're not going to share our presenters' bio sketches with you verbally. We are going to send them out to you after this program, along with the recording and PowerPoints, so that you will get in a day or two a whole packet of information from this presentation in this forum today. We ask you to drop your questions in the chat, and we will take those questions at various times throughout the presentation, the forum, and also at the end. We also ask you to stay till the end because Tiffany, our program manager, is going to be sharing some important and exciting information about services and programs that the IECHI will be offering through the rest of the spring. And we'd like you to be sure that you hear about those so that you can take advantage of them. Today, our forum is focusing on health, heart care, and heart challenge. I knew I was going to do that. Heart care and heart challenge. And the reason we're doing this right now is for three reasons. One, next month in February is Heart Awareness Month, Heart Care Awareness Month. Two, heart-related incidents are the #1 killer of people in the United States. And three, and probably most important, with what's happening with the HR bill out of the federal government and with the changes in the state of California on health coverage, a lot of our Inland Empire residents are losing health coverage or are going to be underinsured. And so we thought it would be really important to share the information on how heart care and heart challenges for us individually, for our families, our friends, and for those clients that we share and serve, whether they're as clients or as patients. So we are delighted to have a very full program today for you. We're going to starting with Dr. Miles Babb, who is a cardiology resident at Arrowhead Regional Medical Center. And then we have Anita Perez and Sandra Escobar, who are going to be talking about healthcare challenges for Indigenous residents, and they're from the Riverside University Health System. Then we have Linda Griffith from San Bernardino County Public Health, and she's going to be talking about Black maternal and child health care and challenges. And then we have Dr. Carr from Loma Linda University, who's going to be focusing on senior health care. So full program, and we are going to get started now. And so I'd like to invite Dr. Babb to open our forum for us today.
Thank you very much, and thank you for having me. This is it's a wonderful opportunity, I think, to speak today. Let me share what I've got for you. Are you seeing it okay?
Yes.
Great. So I'm Miles Babb. I'm a fellow here at Arrowhead Regional Medical Center in Colton. And this is 10 things that you can do today. And there we go. So an introduction to coronary artery disease, if you're unaware. The bulk of what a cardiologist deals with is the progression, diagnosis, treatment of coronary artery disease. And it's epidemic. A third of US adults have some form of cardiovascular disease. There there's 6 million deaths per year, one every 30 seconds. And those in low socioeconomic status and Black, Indigenous, and people of color are at higher risk. In a lot of people's minds, I think that the cardiologist swoops in when there's a heart attack happening, but that's akin to closing the barn door after the horse is out. And so if there's good news to be found here, it's that while this looks grim, this does not need to be your story. There is a better way, and prevention is it. So how do we define preventive care? It's designed to keep something undesirable, such as illness, from occurring. So often advances, especially in medicine, are considered to be these new technologies, new medications with millions in research and development behind them, where we could get really good health optimization, delivering what is available today and making that equitable and available to all patients. Importantly, prevention can be low tech, low cost, oftentimes even free. And that's kind of what I'd like to pitch today, is that there are things that you can do today, some at even no cost or extremely low cost, that could set you up for success in the future. I'd like to start with a warning. Nothing in this talk is new. Nothing here is groundbreaking. You will not be surprised by the things that I say. I think most know what is good for them. And it's not flashy. Real life is not Grey's Anatomy. Certainly there is some cardiologists swooping in heart attacks, but hopefully this approach can prevent people from having to see a cardiologist in the first place. It's a bit tongue in cheek, but I would gladly put myself out of business if it meant optimal health for my patients. Another disclaimer, I recognize that I speak from a position of privilege, and often the reaction of medical advice is, oh, sure, doc, that's really easy for you to say. And I don't want to sound preachy, but I want you to know that this is advice that I give my own family members. This is advice I give people that I care about. I don't know you personally, but when you're hearing me, I'm speaking to you as a family member. And then finally, I think the real disclaimer is, while I am a physician, I'm not your physician. And anything that you put into action from this talk should be discussed with the doctor that knows you best. All right. Housekeeping out of the way. Let's talk about 10 things. And these are the 10. Knowing your numbers, knowing your history, don't smoke, minimize alcohol, eating real food and fiber, exercise and losing weight, improving sleep, minimizing stress, taking medications when they are prescribed to you, and not ignoring symptoms. I'll come back to this list at the end. Number one, knowing your numbers, and especially these three: blood pressure, cholesterol, and A1C are could provide enough fodder for you to speak with your physician at many, many appointments. These three play into your heart health intimately. They're extremely accessible, and they're often covered by insurance in preventative appointments to check a blood pressure, check cholesterol, and check hemoglobin A1C. If you're not familiar with A1C as a lab test, this is a measurement of blood sugar over the last 3 months as it's attached to red blood cells. And this gives us an idea of whether or not somebody has impaired glucose tolerance or diabetes, and which plays into heart disease a lot. Again, you can make an effective action plan over the next year with your doctor just on these 3 points, and I would encourage you to. This is your way to control your health and have a hand in it. I think there are some new guidelines that have come out this year for doctors regarding blood pressure. But importantly, blood pressure, is easy to check. It's an easy thing to do. You can even go to the pharmacy, and those machines that they have in the pharmacy or that you see at a grocery store are calibrated and validated. So these things are achievable, accessible, and I would encourage you to use them. Number two, know your history, both your personal medical history and your family history, if that is possible. Being able to converse with your doctor about your personal medical history is extremely important. The things that have been in your past will affect your future. So then why does it matter what my mother, father, brother, sister had or has? Well, whether we like it or not, biologically, we are similar to our parents. And chances are that you will inherit at least some of the traits, the family traits that make people susceptible to disease. This is what medicine calls a non-modifiable risk factor, or something that can't be changed, but it can be known and it can be managed. So it's important that you know about it so you can have control over it. I'll tell you a short story that I hear once a week in the hospital, I promise you. A 50-year-old guy comes in complaining of chest pain. His father had his first heart attack at 49. His brother had his first heart attack at 51. What is the first thing that I'm thinking? It's very possible that this guy's having a heart attack. Family history is extremely important, but personal history as well. Know them. Importantly, your genes are not your fate. Number three, don't smoke, and quit today if you do smoke. Smokers are more likely to die of heart disease than lung cancer. Everybody thinks about the lungs, that's where the smoke goes, but it's extremely hard on the heart arteries. The good news is that cigarette use is declining across the board. The bad news is that 10% of Americans still choose to smoke. Quitting today is the best thing you can do for your health. In the next 24 hours, your risk of heart attack and stroke increases and continues to go down. In weeks, your blood circulation, lung function improves, coughing goes down. After a year, your risk of heart disease is cut in half from that of a smoker. There are proven methods for tobacco cessation, and your doctor can help you navigate those. I would encourage you to seek them out. If you've even contemplated putting down cigarettes, please ask, because we can do it. Number four, minimize alcohol. Make it occasional rather than habitual. Alcohol plays into blood pressure, cardiac events, every type of cancer, and increased death mortality across the board. Now, this is not saying go teetotal. I'm not saying don't have a glass of wine with friends. That's important for number seven, minimizing stress. But often the things that we do habitually, the ones we aren't thinking about, are the ones that quietly affect us the most. Number five, eat real food and fiber. This one is this is a tough one to preach to people. And it doesn't need to be changed overnight. You don't have to change your entire diet, but small changes can become ingrained. Our small actions become habits, become our future. Decreasing preservative-laden foods, things that are shelf stable and that you can put in a cupboard and come back to in 3 months, decreasing your intake of that will improve your health. Processed foods, ultra processed foods. We could have a long conversation just on that topic, but the point is that whole and fiber rich foods, vegetables, beans should be the bulk of your diet. And the ones that aren't shelf stable are going to be the most healthy for you. If it's going to go bad in the fridge in the next week, that's probably something that's a bit more healthy than something that sits on a shelf for months, even years. And these are small changes. Consider meatless Mondays. Add frozen vegetables to dinner. There's a great quote by Michael Pollan that many of you have probably already read. Eat food, not too much, mostly plants. And that's a great way to sum up this idea. Number 6, exercise and lose weight. Everybody knows this. I told you that nothing here is groundbreaking. Um, I want to empower you. Exercise does not need to be purchasing an expensive gym membership. It doesn't need to be running a marathon. It can be as simple as taking the stairs 2 floors rather than the elevator, walking a few blocks after dinner with your family, alternating standing versus sitting at your computer at work for a couple hours. Exercise is free. It should be accessible to everyone. It's about experiencing the joy of moving your body and feeling good doing it. Number 7, improving your sleep. Sleep hygiene is a tough topic and one that is often discussed in primary care clinics. Um, Minimizing screen time an hour before bed is something that could be considered. We're learning more. The medical system is learning more about blue light and how it plays into sleep habits, melatonin production, etc. But the point is here that consistency and training your body and knowing when it's time for bed will help ingrain those habits. Um, you'll see that a common theme in my talk is that there's uh, that habits play into who we are. If you snore loudly or anyone has ever said that you stop breathing at night, please, please, please consider getting tested for sleep apnea. Sleep apnea can have profound effects on your heart and your cardiovascular system and plays into cardiovascular outcomes overall. Number 8, minimizing stress and identifying your triggers. Admittedly, this is probably my weakest point. Okay, doc, you've taken away my cigarettes. You've told me to eat salad. I can't have wine every night anymore. If I wasn't stressed before, I sure am now. That's, again, a little bit tongue in cheek. But this is about identifying triggers. We all have stressors in our days. I cannot advocate for someone to quit their stressful job, right? That just adds more stresses. But consider scheduling time to unwind at the end of the day. Literally, block out an hour of your schedule. Try relaxation exercises, deep breathing, yoga, meditation, guided imagery. In fact, the American Heart Association this year put out new guidelines emphasizing the importance of minimizing stress, and they put in their guidelines that there's evidence for transcendental meditation. And that one's tough for science-based doctors, right? But the science is there. People do better. You can take charge of your life by focusing on things that you can control. If you find yourself worrying, make a list of the things you're worried about and cross off the ones that you can't change. Focus on what's left. That's how you take control, and that's how you minimize stress. Number 9, taking medications when they are prescribed. Importantly, they may not make a person feel different. Now, there are a lot of reasons why somebody may not take the medications that they're prescribed, some of them financial, some of them social, some of them mental. But sometimes we find that people don't take medications because, well, you gave me this pill, but I don't really feel any different. It may still be working. High blood pressure, going back to number one of the very basic measures that plays into your heart health, high blood pressure very often doesn't make people feel any different. And so when they're controlling their blood pressure with medication, they don't feel different. Why am I taking this? Is this actually working for me? This goes a step further. I want you to challenge your doctor. Your doctor should have a good answer for why you're prescribed this medication. please ask. Health is a conversation for you to participate in. We want to assist in that. Number 10, don't ignore symptoms. Listen to your body. You are the only person living in your body. You know it best, and you will know when something's wrong. Fully half of cardiac events have symptoms that pop up in the weeks prior. In women and people with diabetes, symptoms can be atypical. They're not what you see on television of squeezing chest pain necessarily. They can be vague. If you have risk factors, if you have family history, seek medical care and be assertive and get answers for your questions. Well, if this is not that, then what is it? Write things down in a way that makes sense to you. That includes checking, if you check your blood pressure, write it down. I love when people come to clinic with a list of questions, a list of blood pressures, a list of medications, and their understanding of why they're on that medication. It's the beginning of the conversation. Being an active participant in your own health is not easy, but it is free. And it's how you can be your own best advocate. And that's what's important. Again, here are the 10 things, and I'll restate them. Knowing your numbers, knowing your history. Don't smoke. Quit today if you do. Minimize alcohol. Eating real food, prioritizing fiber, exercise and losing weight, improving your sleep, minimizing stress where you can, taking medications when they're prescribed, and not ignoring symptoms if they pop up. A couple quick take-home points. Again, prevention can be low cost. It can even be free. And again, prevention is not flashy and it's not easy, but it is important. We don't want to close the barn after the horse is gone. And remember, you are your most important advocate. Your doctor can help, and we want to. Please, please, please open the conversation. I wish you many healthy years ahead. Thank you very much.
Thank you so much, Dr. Brab. We have a question for you in the chat. Andrea asks, what recommendations/resources are there for getting people, specifically a dad, to quit smoking when they smoke because they are stressed, and yoga as a suggestion is not necessarily useful?
Yeah, so smoking can be a crutch. Nicotine it does hijack our reward pathways, and people find that they'll turn to smoking or any other habit when they find stress, and it becomes I think number one, the patient has to recognize that association in their mind, that they go to that. It's called motivational interviewing is what we do in the clinic, and we examine what are the reasons that you smoke. And so I would say, Andrea, number one, looking up motivational interviewing and understanding how you elicit those thoughts, because the patient it's like the movie Inception. The patient has to make the idea in their head. Otherwise, they're not going to ever quit. Um, this is why people don't quit until something bad happens, and sometimes not even then. The drive to nicotine can be stronger than logic. So it's about making those associations in your mind and leading the horse to water. You can't necessarily make the horse drink. And then secondly, I think there are these stages of change that I use every day in clinic. If somebody has thought about it or is is maybe they're contemplative. There's pre-contemplative, contemplative, preparatory. If somebody's thinking about quitting, or if they've ever mentioned, boy, I just hate using these things, that's a possibility to intervene. That's an open door. Use that. Oh, really? Why do you say that? Right? And not being confrontational about it, because then people just shut down.
Dr. Babb, you made me laugh because so many of those 10, especially ignoring symptoms, is kind of rampant in my family, particularly with the men. But I admit I do too. I just think I can push through and not pay attention to them, which is why I ended up with an emergency pacemaker. So disclosure to everybody, don't
It's a
ignore your
fully natural
symptoms.
defense mechanism that we all do.
Yeah. So, but thank you very much. That was very to the point
My
and
pleasure.
very clear and not anything we can dodge really now that we've heard it so well organized and defined so clearly. So thank you very much for that. Hope everyone took those carefully and personally, and also to the members of your family, as Andrea pointed out, and also to our clients and our patients. So next we're going to ask Sandra and Andrea to talk to us about the particular heart care and challenges for our Indigenous residents.
Thank you. Can you all hear me?
Yes.
Okay, great. All right. Thank you for having us today. I'm Sandra Escobar, an epidemiologist at the Riverside University Health System as part of the data team, and I'm here with my colleague Andrea, and I'll let her present herself or introduce herself.
Kaku Miahuen. My name is Andrea, GIS Research Specialist for the data team.
Thank you. And today we will be presenting on the heart health of American Indian Alaska Native people in Riverside County. So most of the data that we'll be talking about will be specific to Riverside County. Next slide, please. Here's kind of an overview of our presentation. I will warn that it's a little bit data heavy, but hopefully it will be helpful context for the Native American community in particular. We will be defining the American Indian Alaska Native population in terms of how we study that population. In the data, we'll be going over heart health risk factors for Native Americans, heart disease related morbidity and mortality data, tribal health outcomes for heart disease, and how to align healthcare with Native culture. Next slide, please. So this is kind of a lot on one slide, but the main idea here is we use a definition of Native American American Indian Alaska Native that tends to be kind of exclusive, usually in public health or any population health data, in that it limits the definition as anyone who identifies as American Indian Alaska Native, but it doesn't include anyone who might identify as Hispanic or a multiracial individual. This can cause a lot of problems when we're looking at rates and we want to study outcomes and health trends for specific regions, because a lot of the time we don't have sufficient data to be able to make those determinations. So some of what we've done in our health department is try and make that definition a little bit more inclusive by including people who do identify as Hispanic, which is the AIAN alone group in red there, that broadens our population. And then in the third group that you'll see, we have American Indian Alaska Native in combination. So they can be multi-race, identify as Hispanic. As long as they're identifying as American Indian Alaska Native, that means that they're included in our broader definition. So this helps us a lot when looking at the population, and I think is more representative of the actual Native American population in Riverside County. Next slide. Here's an overview of what that population looks like in the county. In Riverside specifically, there are about anywhere from 8,500 to 33,678 people who identify as American Indian or Alaska Native. And when you look at the population as a whole in the county, that makes up anywhere from 0.4 to 1.4% of the population. And you'll see here in the charts, the gender differences are pretty even throughout, but you'll see that the population really does increase when you're more inclusive in the definition. Next slide. In terms of heart health risk factors for Native Americans, I think some important things that come up in the literature looks at the loss of land and some of the traditional ways of life for Indigenous peoples, and that depends a lot on natural resources for food as well as cultural practices. I know Dr. Babb explained a lot about some of those uh, more downstream effects. But food, diet, cultural practices, managing stress, things like that, and the loss of those things because of the ongoing history with the native population are contributing factors. That has caused drastic change from the traditional foodways for Native Americans to more mainstream Western diets. So more processed food, more less fresh, less availability and access to fresh foods and things like that. We also think that things like unemployment, poverty, and food insecurity contributes to heart health risk, and that might be because of the increase in stress because of that. And we see that in high rates of hypertension, diabetes, and obesity for this population. Next slide, please. So this is kind of a more broader framework on what that looks like in more concrete terms. So in the middle, you have the loss of use of traditional food systems. We know that diet plays a really huge, important role in heart health. So because of the things that you see sort of at the top, like the decrease in the number of plant and animal species, as well as the decrease in density of these species, the loss of transfer of cultural knowledge to youth, the loss of land itself and the ability to harvest food from these traditional lands, the loss of time and energy that people used to take for harvesting, and now, might be used for employment and more sedentary jobs. The availability of new foods that are acceptable, that aren't always great, that have huge Western influence, as well as an increase for environmental contaminants. Uh, all of that plays into what it means for the loss of traditional food systems. And what this causes are, less culture-specific food activities. That is a huge part of Indigenous culture, an increase in sedentary life, a decrease in dietary diversity, and also a decrease in cultural morale. And as was highlighted in the previous presentation, we see this in the population by the increased rates of obesity, diabetes, things like alcoholism, heart disease, and other chronic health conditions. Next slide, please. So in terms of data in Riverside County, what we see when looking at the data at the population level, and these are using, the more restrictive as well as the more inclusive definitions here, compared to the population overall in Riverside County, Native Americans tend to have higher rates of poverty, no matter which group you're looking at. So that's something important to consider when thinking about social determinants that might be contributing to long-term effects like heart disease. Next slide, please. There are also data that shows that Native American households are more likely to receive food stamps and SNAP in Riverside County, just slightly more than the overall county average. And this is true for all three groups. And when you think about the kinds of foods that a lot of people who are on food stamps or SNAP receive, they tend to be more processed. That's something else that's important to keep in mind. It's not always culturally aligned with the traditional diets that are healthier for Indigenous people. Next slide. And then when it comes to healthcare access and quality, this is data showing some this is data on healthcare access from our CHA, or Community Health Assessment, that was published a couple years ago. When you look at the data by race ethnicity, you can see that American Indians, Alaska Native report the highest rates or the most impacted by delayed care or did not receive any care compared to other groups. And this, could be due to systemic issues within the healthcare system, such as long wait times, provider shortages, and those are about half of what contributes to delayed care for these communities. Next slide, please. In terms of more concrete health outcomes, we do see in Riverside County that Native Americans have or are more likely to report having had borderline high blood pressure and also have high rates of blood pressure. So when you combine those two, they are more likely than the general population to have ever been diagnosed with either high blood pressure or borderline blood pressure. And just an important distinction with this data, we're only talking about the most inclusive American Indian population. Next slide, please. There are also high rates of obesity compared to the general population for Native Americans in Riverside County. You'll see that in that top most chart graph or the bar. 42.5% of Native Americans report having obesity compared to only 34.3% of the general population of Riverside County. So these are all things that are sort of preventable. They're more upstream of actually having like a heart attack or a stroke or things like that. So these are things that I think our community can help prevent or just take care of a little bit earlier to prevent those more adverse health conditions. Next slide, please. And saying that, when we look at mortality data specifically, heart disease is the leading cause of death for Native Americans in Riverside County. It was mentioned earlier today at the beginning of this meeting. It is a leading cause for almost all race and ethnic groups in the county, with the exception of Asians. But this is true also for American Indian and Alaska Native, heart disease being the first leading cause of death, and then stroke being down at the fifth. Next slide, please. And when we break this down and look at it by separate groups, we'll see that the non-Hispanic, or the most restrictive definitions, tends to match the higher rate in the county. So 166.5 deaths per 100,000 people are due to heart disease. Next slide, please. And when we break this down by gender, Native American females actually have higher heart disease mortality compared to males in Riverside County. And this is interesting because it's the opposite for every other race and ethnic group. So males tend to be have higher rates, but in this group in particular, it is the reverse. Females tend to have higher rates of heart disease mortality. Next slide, please. So I'll pass it on to Andrea, and she'll talk a little bit about tribal health in Riverside County.
So we look at our county as a whole. We have 12 federal reservations. And we have Agua Caliente Indian Reservation, which falls within that Palm Springs area. So they have a very large non-native population dispersed throughout the reservation. There are limitations when it comes to analysis. So for the sake of looking at what tribal health looks like on a reservation versus urban native health, we did analysis of age-adjusted mortality rates for heart disease. And there was a difference in health outcomes due to that population makeup, with the Agua Caliente Reservation having a larger non-native population than the other reservations. And in addition to the proximity to an urban hub, meaning they have more access to medical resources. Next slide, please. So this shows you the other side of our county. So the tribal areas excluding Agua Caliente Indian Reservation included both reservation and acquired parcels that people might live on. All of this was aggregated separate from the Agua Caliente to highlight what might reflect true reservation health outcomes. And the mortality rates include residents regardless of race. So they could have been white or non-native. Again, for all other tribal areas, natives made up more than 90% of the population. And this was not exclusive for tribal enrolled citizens. Okay, we can go to the next slide. So I want to point out that these two charts are not comparable. They're using two different denominators for their population, which is why you'll notice that the Riverside County rates are slightly different, but they are pretty close together. And that's because we looked at one vintage for that AIAN population versus looking at what's the population by these boundaries. It's another data set within the census for the Agua Caliente versus tribal areas. So again, what our point was, are we seeing a different health outcome for tribal areas that might be more rural? And it is 161 compared to Agua Caliente at 140. And while this isn't conclusive, it does give you a general idea that there might be more challenges on these tribal areas, tribal reservations, or tribal areas that aren't as close to medical resources. Next slide.
All right, and just to finish up, thanks, Andrea, for going over that. Our last slide here talks about how to align healthcare with Native culture. And I think the understanding when looking at a lot of the literature and just working with Indigenous communities, there is this understanding that professionals focus on improving the overall health of Native Americans and well-being of society should, by extension, be concerned with the physical environment and general well-being of the earth. You know, a lot of our food comes from the earth, animals and plants and all of that. So you have to kind of, and this is part like a huge cultural practice, having that connection with the land and what that means for your own health, meaning we're not separate from the earth. Another aspect is revitalizing the traditional diets and increase access to affordable and healthy foods. Addressing the mental health and stress by acknowledging the impact of loss of these traditional practices, the loss of human connection and community strength, and finding ways to rebuild those. And of course, enhance healthcare access and education, not only for tribal areas, but just Indigenous and Native American people in the county as a whole. So that is, next slide, please. I think that's our last slide. If you have any questions, please feel free to email us. And we are a public service for the county and for the Inland Empire. So if you need data, please feel free to reach out to us as well. Thank you very much.
Thank you both so much. It looks like we have a question in the chat. Does the rural living factors impact the limits in health services and other facets of their lives, such as food, employment, etc.?
I will give a lived so we have a California Indian Nations College. They are based in Palm Desert, and that does continue to be an issue, having food access, whether that's because there's no food stores, but also poverty, being able to afford good food. With the changes in the federal government, it has impacted either employment or access to services. So from that angle, like talking to community, it has directly impacted them. But there is Indian Health Services, RCBC, and they do provide healthcare to tribal enrolled citizens, and that is based in San Bernardino. So it's accessibility in regards to like transportation for people to get there and get to their meetings or get to their appointments, childcare, all of that does feed into it. But if Sandra has something to add.
No, I think you covered it, and maybe I'll just add a lot of reservations tend to be in rural areas, so there is that connection there. It's a little bit harder to study tribal health outcomes. I know that's something that we're working on, but they do require additional methods because sometimes the data is just not available at that level. So it is something that we're thinking a lot about. For this population in particular.
Thank you so much for that presentation for Sandra and Andrea. That really ties in, and that's why it was my question. The IHI has completed their second rural health report for the Inland Empire, but in both reports, we have not addressed the Native American and indigenous populations. And so we are talking about doing a special rural health report around that. So we will be in contact with you further down the line. Very good, very interesting information. Thank you so much for your presentation. Really highlights the challenges for our Indigenous residents and the importance for us to address that collectively. So we do have a couple of comments in the chat. Tiffany, do you want to read those just to share with everyone?
Yeah, so we have Mila, who says that these data are important to underscore the validity of the idea to return to tribal traditions and lifestyle as regards overall health of both people and the land. She is all for that idea, and she tries to incorporate this in their daily life through gardening and growing of their own veggies and herbs.
Good job. Want to come to my house and do that? I am not a gardener. So we now will move to asking Linda Griffiths to talk about the challenges, heart challenges for maternal child health, particularly in the Black community.
Thank you so much for this opportunity to be here to present today. This particular topic is very close to my heart because my background is high-risk OB. And a lot of the moms that presented to labor and delivery had complications with either chronic hypertension or to develop preeclampsia during pregnancy. So, but we can't look at heart health without looking at the historical perspective of the impact on enslaved people in this country and how their posterity has been impacted as well. Next slide, please. So when we look at the historical perspective, we start with the legacy of harm. At one point in this country, it was a lot of unnecessary cesarean sections were done on Black women in the South. And I can speak from a perspective that I'm familiar with because I was born in the South. I lived there most of my life. And so this is not something that I've read about. This is something I've experienced through family, through friends, other relatives. And so I'm very familiar with what I'm talking about here. There were a lot of forced sterilizations without consent at one point in the South. And there was this racist myth that Black people have a higher pain tolerance. And that's not true, but this is what has been projected. And Black women in particular had no autonomy over their own bodies. And so when you continue to live under these circumstances, naturally, you will naturally have an impact on your body. When we look at institutional racism, experiencing discrimination in every system, every institution in this country, was education or healthcare, employment, the criminal justice system. This is real data. This is not theory. This is not make-believe. This is America's history. There was the myth of the strong Black woman, the angry Black woman. That actually originated during slavery because the family was so fragmented many times that the moms and the grandmothers had to step in to manage the families when the men were no longer in the homes. And so out of that came the strong Black woman, the angry Black woman. This has been projected. A lot of times Black women were expected to just grin and bear, no matter what violations were perpetrated against them. Don't take it to heart. We're not allowed to have our own feelings, our own emotions. And so this has played a toll on the health of Black people in general, Black women specifically. We look at evidence shows that as a result of racism and racist policies, Black women experience chronic stress that contributes to a higher allostatic load than other women. And this constant exposure and repeated exposure to stress, in the long run, there's a physiological cost, and it leads to disease at some point. It always does. Next slide, please. So when we look at the effects of stress on the body, and I just picked out a few things, there was a whole list. Stress impacts every system in the body. And so I'm looking at here, we just look at psychological stress or mental stress or psychological exhaustion, however you want to name it. But it depletes you after a while when you're continually exposed to stress. You're sometimes left feeling detached, just feeling drained, unmotivated. The hormonal imbalance. Cortisol is a very important hormone, and adrenaline, very important, plays a vital role in the body. But in spurts, it's healthy. Spurts of cortisol is very healthy. We need it, the fight or flight. That's important to us. But sustained high levels of cortisol can lead to significant health issues. And I think this is what we're seeing in a lot of our moms. We talk about physiological wear and tear on the body from stress. Headaches, increased heart rates, increased blood pressure, insomnia, depression, all these issues we're seeing with our moms in pregnancy and people in general. Talking about digestive problems, gut problems, problems with ulcers, IBS, with belly cramping, bloating. It's something that if I don't experience it, but when I talk to other families, other family members, people are people are actually expressing what they're feeling and how they don't feel that they can actually get the care that they need. And that's the misfortune of all of this, is that because of the mistreatment in the healthcare system, there are a lot of families, even today, they would benefit from annual screenings because of the mistrust. And it's not that it's not warranted. They are not being seen for conditions that can be actually reversed or prevented with early detection. And that's what bothers me. Next slide, please. So cardiovascular disease, disproportionate impact on Black women's health. Next slide. So Black women in general are disproportionately at higher risk for poor health outcomes. We're seeing this with pregnancy mortality rates. They're increasing. I've been in nursing almost 35 years. And you would think with all the advances in medical technology, we would have better health outcomes, but we're not having better health outcomes. As a matter of fact, the United States has some of the worst maternal health outcomes than any other first world country. So we're looking at hypertension. It has the highest prevalence. Black women have the highest prevalence of high blood pressure, and over 25% have it under control, meaning that either they're not managing it well, they're not taking their medications, they're not following the doctor's orders, they're not losing the weight, they're not eating the diet. And so this is concerning, because if this is not under control, it only leads to further complications and further heart issues. Strokes are 2 times higher in Black women. Heart disease, they're at higher risk of dying from heart disease at a younger age. and it counts for 1/3 of maternal deaths. And then there's other cardiovascular conditions besides hypertension. There are arrhythmias, there's coronary artery disease, there's peripheral vascular diseases. All these diseases our population are experiencing. And in pregnancy, it's very difficult to treat women because they're reluctant to take any medications during pregnancy. And so we know that preconception health is the best indicator of pregnancy outcomes and birth outcomes, but it's very difficult getting these moms to go in for annual well woman screenings, go in for oral health care that all impacts their pregnancy. So it's almost it's an uphill battle that we're fighting, trying to take care of our childbearing population. And so we're hoping, with different community partners to get the word out, to share this information as much as possible. Next slide, please. So we're looking at some key risk factors for heart disease, and it's already been mentioned before, but we're looking at controllable factors, just some lifestyle changes. If people were willing to make the lifestyle changes, what I've realized after working so long in healthcare, if people don't value their own health, they're less likely to make the lifestyle changes. You can provide all the education, you can provide all the resources, but it has to become important to them. And if it doesn't become important to them with everything that you provide, even outlining the benefits of making these changes to improving their health, it's very difficult. You will have some takers, but unless there's a buy-in, there's not really a lot of change, significant change, to change the stats. That's what we're not seeing. So we know that high blood pressure damages the heart and the arteries of the heart. We know that poor diets in saturated fats, diets high in sodium, high in sugars, these diets are very unhealthy for anyone, and definitely with someone who have not had practice healthy lifestyle habits throughout their lives. We're looking at obesity and the work of the heart, extra burden on the heart for pumping blood throughout the body. We already know about smoke, nicotine, the carcinogens, over 4,000 poisons in cigarette and tobacco alone. We're looking at inactivity, which weakens the heart muscle. That's why physical exercise, moving is so important throughout the day. At least 15 minutes, if you could walk 15 to 30 minutes a day, if you can get people to move that much, that would be great. And of course, diabetes, insulin resistance, increases the blood viscosity and increase the risk for heart disease. These are controllable factors. These are things that people could do if they choose to improve their own health. But like I said, I've worked in public health 10 years before leaving the hospital. It's very difficult to get people to make these changes. And we know what the consequences will be, and it's not good in the long run. And so on the other side, you have the uncontrollable factors, of course, age, gender, race, and genetics. Next slide, please. So these stressors does impact a pregnancy. Stresses during pregnancy can trigger the release of oxytocin, which is the hormone that initiates labor, starts the contraction. And so with these moms who usually we come in, present with, a lot of them have hypertension already. A lot of them are diagnosed with diabetes prior to pregnancy or pre-diabetes. A lot of our young moms are overweight. Some are obese. And all these conditions have an impact on the development of their fetus, have an impact on the placenta function. And we're seeing more now with impaired placenta perfusion. And so when we look at all these complications, and the main three that I've seen over the years is preterm birth, fetal growth restriction, and low birth weight infants. Now, these three conditions, the fetal heart is impacted with all three of these fetal conditions because the baby is not mature, the organs are not mature. So usually the baby have smaller heart chambers. There's impaired pumping function. And usually there's some form of hypoxia where the baby's, the organs, the tissues are not getting enough oxygen. And these babies are usually premature. They're in the NICU. And usually they will be followed up the first few years or maybe the first 5 years of their lives with a primary care provider or cardiologist, because usually they have heart issues. And this is very expensive for the healthcare system, very expensive for the families as well. Next slide. The next slide, please, is a slide from American Heart Association. This is from 2025, American Stroke Association. These are the new parameters that they're recommending. We know that people who are physically fit, athletes, or people who train for sports like the Olympics, these parameters may be a little different, but for the average person, these are the recommendations for normal, normal blood pressure. And then you can see the abnormalities. And if once you're monitoring your blood pressure, which I recommend over 30, that everyone monitor their blood pressure at least once a week, so you can have a baseline. So if there are any changes, you know what the changes are and keep a record of it and report that to your provider. But these are the guidelines from 2025. Next slide, please. And this is from the Cleveland Clinic. This is from 2024. They may have updated this particular chart, but I didn't see a more recent one. So we know that weight, obesity can impact your heart health, and it increases your risk for diabetes and other health complications. And so this is something you can share if you'd like. Next slide, please. So why should heart health be important to Black women in particular? If someone has a genetic predisposition to heart disease, that's not inevitably mean you will have heart problems. But it does put them at greater risk. And there's a saying, and I grew up with this saying, genetics load the gun, but lifestyle pulls the trigger. And I believe in a long, productive quality of life. And that's the reason I went into public health. I would like that for everyone. But like I said, that's a choice. But these are things that we do recommend in public health. And these are some of the things that Dr. Babb mentioned as well. Maintaining a healthy weight. That's something you can work with your doctor on if you have an issue with, if you're overweight and you want to bring your weight down to a healthy weight. That's something you can work with your doctor. He can recommend a nutritionist. They can work out a health plan for you, an exercise plan for you. Quit smoking. Not cut back. Quit smoking. Because smoking is detrimental to your health. There's no getting around it. Eating a healthy, well-balanced diet. I eat a plant-based diet. That's not for everyone, but you can cut back on the processed foods, the high sodium foods, the high fat foods. That's very, very important. Adequate rest. That's very difficult for everyone. It is for me. I'm trying to do better, but we're all busy. So we have to make it a priority in our lives because it does impact. I can tell the difference when I don't get enough rest, enough sleep. Stay physically active. Like I said, if you can move at least 15 minutes a day, 10 or 15 minutes a day outside, sunshine, we need the vitamin D. That's so, so important. Maintain a healthy blood pressure. Know your numbers. That was mentioned before. I monitor my blood pressure at least once a week. I know what it is. So when I go into my dentist and he monitors my blood pressure, I say, no, that's not what it is. I know what my blood pressure is. Or if I go to my doctor annually once a year, I have a record of my monthly blood pressures. Utilize stress management techniques. There's so much on the market there right now. There's yoga, they're talking about meditation, out in nature, just walking out in nature, listening to classical music, Surround yourself with positive people. Be grateful. List 10 things you're grateful for. Gratitude is so important. And maintain healthy relationships. Sometimes you have to cut people loose because they're very toxic and they bring that toxicity into your environment. And that can be very, very stressful. Next slide, please. So we were talking about childbearing population, our birthing moms. We want them to be aware of these symptoms. We want them to report these symptoms immediately. If this is something you can share with your organization, this slide, if you deal with pregnant moms, moms of reproductive age, this slide is so important because these symptoms need to be reported right away. Recognizing these warning signs is so important. It impacts the pregnancy, can impact the outcome of that pregnancy, and the health of that baby is so important because we want moms to carry the babies to term as much as possible. So what we usually see is the severe headaches and vision changes. May have chest pain and shortness of breath. Decreased fetal movement is one of the things we're noticing, part of the femur team, and this is one of the factors that moms are identifying, but they're not acting on it immediately. They're waiting a day or two to report that they've noticed decreased fetal movement, and that's not good. And usually there are poor outcomes when they do that. Swelling and pain or redness in the legs and arms, trouble breathing, heavy bleeding after pregnancy, elevated fevers, changes in vision. These are all warning signs that should be reported during pregnancy and postpartum because moms can still have hypertension after delivery, and it can put her at risk for maternal death a lot of times if it's not managed. They wait too late, and by the time they go in, sometimes it's too late for anything to be done. So the next slide has the references for all the slides. And when I present this to Tiffany, I'm going to actually put because it has not been approved yet, so I can't share it today with you, but I'll have the reference on each slide. So it would make it so much easier if you'd like to go back and look at that reference for that specific slide. And that's it. If you need to get in contact with me, that's my contact information for San Bernardino County.
Linda, thank you so much. That was really great information and really detailed. And I appreciate the work you did on that and your enthusiasm for advocating for Black women and their children. So thank you for the presentation.
You're welcome. You're welcome.
Are there any questions, Tiffany?
I do not see any currently, but thank you again so much, Ms. Griffith, for providing that as a Black mother who had a C-section. It was medically necessary, but it was incredibly stressful going through that process and worrying about all the different ways that I could be discriminated against while being incredibly vulnerable with two small children. So thank you so much for providing that imperative, necessary historical context and information.
You're welcome.
And now we're going to ask Dr. Carr to talk to us about seniors, heart health, and challenges, because if we're not seniors yet, we're going to be. One of those inevitable things.
Sounds good. Thank you. I'm just going to share my screen here. Are you able to see my screen here all right?
Yes, thank you.
Okay, thank you. All right. So I'll be touching on how we can help our senior adults live heart-healthy lives. And I'm going to be presenting an evidence-based lifestyle medicine approach. I am a fellow in the preventive medicine department here at Loma Linda University Health. And for those folks who have not heard of preventive medicine, it really is sort of the best type of medicine. You've been hearing Dr. Babb, some of the other folks talk about how we can really lean on prevention. So let's start with why this matters. As we've heard throughout this presentation, lifestyle factors are really at the root of most cardiovascular disease, but the critical point is that they're modifiable at any age. So some of the statistics show 6 in 10 adults have at least one chronic condition, while 4 in 10 have 2 or more. And chronic conditions account for 8 of the 10 leading causes of death in the US. But what can give us hope is that nearly half of these premature deaths can be prevented with healthy lifestyle behaviors. And we know our interventions are effective because behavioral counseling interventions are associated with a 20% reduction in total cardiovascular events in at-risk adults. Yet most older adults aren't adhering to these established lifestyle guidelines, which represents a significant gap that we can address. That gap is our opportunity, and that's where you all come in. So, we know lifestyle factors cause most cardiovascular disease. We know behavioral counseling works and reduces events by 20%, but most older adults aren't following the guidelines. So how can we close this gap? Well, one approach is the 6 pillars of lifestyle medicine, and these are similar to some of the 10 things that Dr. Babb had brought up earlier. But this is really a simple yet systematic evidence-based framework that was developed by the American College of Lifestyle Medicine. So I'm going to touch a little bit on each of these. I know we've already gone through them, but repetition is key. So with nutrition, we know that a Mediterranean and DASH diets aren't just healthy, but they reduce cardiovascular mortality, heart attack risk, and they improve blood pressure and cholesterol. For physical activity, even if patients can't hit the 150 minutes per week, any movement helps older adults. And sleep is now recognized by the American Heart Association as an essential cardiovascular disease metric. Stress management, we know that chronic stress accelerates cardiovascular disease, avoidance of risky substances. We've heard a lot about tobacco cessation today, but what's really helpful is that benefits can be seen at any age. So even if we have patients in their 70s or 80s. Social connections, this one can surprise folks, but meaningful relationships are essential for sustained behavior change, is particularly in older adults. And what's powerful about these pillars is that they all work together. So if you have a patient that improves their sleep, they often manage stress better, which then helps them make healthier food choices. It's a bit of a positive cascade. So we were talking about how 8 of the 10 leading causes of death are driven by chronic disease. Well, these 6 pillars give you a practical way to address the root causes and not just treat each individual symptom. The framework isn't necessarily about overwhelming patients with 6 changes all at once, but it's about having a systematic approach so you can really meet your patient where they're at and focus on what matters most to them. So if you can even focus on one pillar, that can make a meaningful difference. And you can think of these as your menu of options. You'll choose what's most relevant for each patient. So now that you've learned a little bit more about the 6 pillars, how can we implement this in a busy practice model? Well, this is where I'm going to introduce what we call the 5A model. It's really a clinical roadmap. It's a validated, efficient framework for behavior change counseling. So the 5 A's are assess. You want to ask about current behaviors and their readiness to change. This should take about a minute or less. Next, we're going to advise. So we want to give clear, personalized recommendations, which should take about another minute. Then we want to set goals together with the patient, which can take a couple minutes. And the last 2, assist and arrange. So you want to provide resources and address barriers, which can take a little bit longer, a couple minutes to 3 minutes. And then in particular, arrange or schedule follow-up, which should take about a minute. So what we've seen is that most of us do a really good job with 1 and 2, but steps 4 to 5 assist and arrange, these ones tend to be done the least often, yet they have the greatest impact on lasting behavior change. So if you take one thing away from this slide is please don't skip the follow-up. All right, so now let's talk specifics. We're going to go into nutrition. We've already mentioned Mediterranean DASH diets have the strongest evidence because they're associated with lowered cardiovascular mortality, reduced heart attack risk, improved blood pressure, cholesterol. But how do we give clear, simple messages to our patients? So one, we talk about what we can add. Let's add fruits, vegetables, whole grains, beans, nuts. Having them choose less processed foods, less sugary beverages, things with less excess sodium, and then when possible, suggesting switching for plant proteins rather than meat protein. One thing we do have to keep in mind for older adults is adequate protein is essential to help prevent any muscle loss and frailty, particularly during weight loss efforts. But what I kind of want to emphasize here is that you don't need to be a nutrition expert. You just have to give clear, simple messages to your patients and then utilize the team-based care. So refer to a registered dietitian for more intensive counseling. And this on the right side of the screen, just want to highlight, this is from the American College of Lifestyle Medicine. This is their plate approach. So we have half the plate is fruits and vegetables, and then the other half is quarter protein and quarter whole grains. Now, this is what I have my patients work towards. I know they're not going to get there right away, but you see how the proteins all show plant-based proteins is kind of just helping our patients get there, but it's not going to work for everyone, and we do have to culturally tailor this approach. So next for physical activity, the goal is really 150 minutes per week of moderate activity, about 30 minutes a day, 5 days a week. But for older adults, how I frame it is I want them to start where they are. So any movement is better than none. And these patients are going to have very real concerns, whether it's fear of falling, chronic pain, or lack of motivation. So you want to have ways to approach this. With fear of falling, I recommend supervised programs, chair exercises, or even water aerobics. For chronic pain, I mentioned start with gentle, low impact activities. And when they have a lack of motivation, we suggest group activities because we know the evidence shows that social support works better than going it alone for older adults. And often walking is the best starting point for them. It's effective, safe, and accessible. All right, so the three more pillars that are often overlooked but very critical. We've already mentioned sleep, recognized by the American Heart Association as a critical cardiovascular health metric, and has been mentioned earlier. I think Dr. Babb mentioned you want to particularly screen for sleep apnea. It can make a big difference in their cardiovascular health. When it comes to stress, we know psychological health plays an underlying role in all lifestyle behavior change. So what we can do is teach simple techniques like deep breathing, mindfulness, and enjoyable activities. Now, social connectedness, like I mentioned, this one's really powerful. Social connections, particularly positive social connections, are essential for helping patients sustain behavior change and improve their health span. We want to assess for social isolation. It is a cardiovascular risk factor. And then we can connect our patients to community resources, senior centers, faith communities, and volunteer opportunities. Okay, so now let's talk about how can we effectively communicate behavior change with our patients. The goal is to collaborate and not just tell them what to do. Most of the time, patients even know what to do. So what really matters to them is someone to get them there. And you can do this by using what we call motivational interviewing. So how we do motivational interviewing is we ask open-ended questions. Instead of saying, do you exercise? We try, what concerns you most about your heart health? We want to avoid commanding language. So instead of telling a patient, you must exercise, you got to exercise, we try, well, what type of movements do you really enjoy doing already? And the biggest thing is helping patients recognize the gap between their own values and their current behaviors. So if they say, I want to see my grandchildren grow up, you want to help them see what are the current behaviors that they're doing that don't necessarily align with these goals. So let them voice their own reasons for change. Along with these come empathy, so acknowledging that change is hard. We want to build on successes, celebrate small wins. Overall, this approach increases patient motivation and engagement. Okay, so how do we make this work in a busy practice? The reality is that short office visits aren't the most conducive to effective behavioral counseling. But like I've mentioned earlier, you don't have to do it all yourself. You rely on team-based care. So this is not about adding more to your plate. It's about leveraging your team and your community resources. Effective interventions can be delivered by primary care providers as well as specialists, registered dietitians, physical therapists, psychologists and counselors, social workers, community health workers, and even health coaches. So at each step of the process, no matter what your role is, you want to assess, advise, and refer when appropriate, and remember to arrange follow-up to check up on their progress. Now, what community resources exist that we know work? Well, there's the DPP, or the Diabetes Prevention Program. That's a nationally recognized CDC program that is a structured lifestyle intervention that's been proven to reduce diabetes risk, and it's often covered by Medicare. There's cardiac rehabilitation that involves exercise, education, and support, and it's often covered by Medicare for qualifying conditions. There's senior centers and YMCAs, so that's a great way to get group exercises, social activities, and those are often low cost, if not free. And you can find local programs through the CDC has a registry for all their DPP lifestyle changes, as well as the AHRQ toolkit, and I'll share more about these resources here at the end. So older adults do face unique challenges, and it's important that we address these challenges head on. So when patients come in with multiple chronic conditions, you want to prioritize what matters most to the patient just by simply asking at each visit so that we can make sure that they align their goals with their values. Polypharmacy can be frustrating, but it can also be motivating for patients. So you want to review their medications and consider deprescribing when it's appropriate. Mobility limitations, we've talked about this. We can advise adaptable activities and refer to physical therapy. For a fixed income, we can connect patients to food assistance and emphasize affordable options. For transportation, we can often offer virtual telephone follow-ups and assist with referral to transportation services. And when it comes to cognitive changes, you want to involve the family and use simple written instructions, aligning interventions with patient values, really making it more fulfilling for you and the patient. So a few considerations for our Southern California and Inland Empire living. There are a few unique challenges. So heat exposure, you want to recommend activities in the early morning or early evening and encourage hydration. There's car-dependent communities here, so that makes transportation a barrier. High cost of living can affect food affordability as well. But some of the advantages are year-round activities, our diverse cultural food traditions, and strong network of senior centers. And a tip is to learn about the cultural food traditions of your patient populations and really build recommendations around familiar healthy foods. Okay, so you say, I want to do this, but there isn't enough time. So as we wrap up here, this is a quick reference for what you can do at each visit when you're in a pinch of time in about 5 minutes or less. So first, you want to ask just one question on a scale of 1 to 10, how ready are you to make a change? And then you based your answer on their readiness. So if they have a low score, they say 1 to 3, then you can express concern, provide some information, but you're really not pushing at this point because the patient simply isn't ready. Now, if they're more of a 4 to 6, you want to explore their ambivalence, discuss pros and cons. But if they're ready, they're at a 7 to 10, you can help them set specific goals and make an action plan. Then you want to offer a resource, a handout, a referral, or community program based on their level of readiness, and then schedule a follow-up, even if it's a simple brief phone check-in. So you want to remember that each additional counseling step increases patient motivation and engagement. All right, so let's wrap up with 5 key takeaways. We know lifestyle medicine works. Behavioral counseling reduces cardiovascular events. You can use the 5A model as a framework, especially focusing on assist and arrange. You don't have to do it alone. You want to leverage your team members and community resources. And you want to meet patients where they're at using patient-centered communication. And remember, follow-up matters. So sustained support over months produces lasting change. And the bottom line here is small, consistent efforts in lifestyle counseling can make a meaningful difference in your older patients' cardiovascular health. So here are some resources that were brought up earlier. The American Heart Association has an online calculator for preventing cardiovascular disease risk. There's the CDC registry for diabetes prevention programs. As far as professional development goes, you can look into motivational interviewing training courses. The American College of Lifestyle Medicine also has board certification available for all healthcare providers. And then there's really helpful patient education materials through the American College of Lifestyle Medicine, whether it's their whole food plant-based plate or the different 6 pillars. The American Heart Association also has an Answers by Heart fact sheet that can be helpful. And then here are my references. And thank you for your time.
Wow. Dr. Carr, thank you so much. That was great. And really helpful for all of us, whether we're seniors now or seniors later. That was a lot of good information. And I realized that my doctor does a lot of that. She's very patient with me. So, Tiffany, do we have any questions for Dr. Carr or anyone else?
Yes, it looks like we do have a question for all the presenters.
Okay. Linda did have to step off.
The question is around tobacco smoking. Sorry, my computer is having a hard time today. When you say quit smoking for CVD health, is that tobacco smoking or any kind of smoking?
Anyone can answer that.
I can take it. Any kind of inhalation of combustible plant material is detrimental to endothelial function. So when we're talking about heart and heart disease, what cardiologists are thinking about is the inner lining of the blood vessels, and those combustible plant materials, they release mediators that damage the inner lining of the blood vessels and contribute to hardening and progression of arterial disease. So really any smoking is detrimental to health, no matter what it is that you're inhaling. And is vaping a safer alternative? Really, it's not. We're finding out that there are other chemicals, chemical mediators in vape products that they tend to stick in the lungs. And we don't know the full downstream effects of vaping yet, as it's so new on the scene.
Thank you. I was going to ask about vaping. Because that's impacting our young people so much. Any other questions? If not, Tiffany, you want to take a minute? I ask all of you to give us 1 minute so Tiffany can share some upcoming events. But also I'm putting our website in the chat so you can go on our website, and we have an upgraded website, so go visit it anyway. But there's also programs and services on the website. We have another question.
Okay, it looks like we don't have another question, so I'm going to go ahead and share my screen. So this spring we are doing a few things at the IHI. So we have some QR codes that you are welcome to scan so that you can get access to this information. We have an advocacy academy. We know that there is a huge importance when it comes to civic engagement. When creating those meaningful changes and supports, especially as we have heard in both the Black and Indigenous community. A lot of historical situations have taken place that have impacted the ability for people to have equitable access to heart health care. So we have crafted an advocacy academy that showcases the importance of the legislative process and where people can, at the very end, create their own civic engagement activity or community activity with legislators. Another key aspect is health literacy, as we have listened to both Dr. Babb and Dr. Kaur speak about the importance of heart health. We also want to showcase the importance of health literacy and understanding when it is most important for children to be reaching out to their doctors, emergency rooms, or urgent cares. So we have crafted a workshop for professionals who support both the early learning services for children and all. And then we also have our newsletter, which we are incredibly excited to continue to showcase upcoming events. So please feel free to scan any of these. And I've also put in the chat a link to our post survey. Our health education forums are currently being funded by the Inland Empire Community Foundation. And so we're incredibly excited to be one of their grantees. So please feel free to put in your information into the post chat and the pre-chat so that we can continue collecting data on what is most important within these health education forums so that we can best tailor them for our community. Thank you so much.
Thank you, everyone, for joining us today. Thank you for our presenters. They were all just absolutely amazing. And I know we took a lot of information away for ourselves, our families, and for those we serve. Have a great day and a great weekend. And we'll see you in March, hopefully, for our legislative forum on March 13th. More information will be coming out. Thank you so much.